السلام عليكم ورحمة الله وبركاته. محاضرتنا اليوم هي Polycystic Ovary Syndrome. أقدم لكم نفسي دكتورة منال ناصح، أخصائية النسائية والتوليد في كلية الطب جامعة كربلاء. Objective of the lecture: what is the student must to know, definition of Polycystic Ovary Syndrome, clinical diagnosis and management, complication of the disease, which is either immediate or long-term complication. What is nice to know is the pathophysiology of Polycystic Ovary Syndrome. How can we define Polycystic Ovary Syndrome? To define Polycystic Ovary Syndrome, we should put in our mind it is an endocrine disease. It is the most common complex endocrine disorder affecting women in their reproductive years, characterized by androgen production and ovulatory dysfunction. It was initially described by Steen and Leventhal in 1935, and for that disease is called Steen-Leventhal syndrome, and then the name will be changed for Polycystic Ovary Syndrome. How to diagnose Polycystic Ovary Syndrome? We have many criteria to diagnose Polycystic Ovary Syndrome. The most common one and the most famous one is Rotterdam criteria. Rotterdam criteria depend on presence of 2 out of 3 of these symptoms in order to diagnose Polycystic Ovary Syndrome. We have polycystic texture of the ovary by ultrasound, anovulation or oligoovulation, clinical or biochemical hyperandrogenism. Presence of 2 of these symptom in the patient, or clinical or investigation which we do for this patient. Presence 2 of these criteria will diagnose the patient of Polycystic Ovary Syndrome. From these we have four different main phenotype of Polycystic Ovary Syndrome will be identified: anovulation, ultrasound scan, hyperandrogenism. Anovulation, that means that the patient presented to the outpatient clinic complaining from either amenorrhea or oligomenorrhea. Ultrasound, that means the patient have a clinical picture by ultrasound suggestive this patient have a polycystic ovary disease. Hyperandrogenism, that the patient mean that either she have a clinical or biochemical hyperandrogenism, mean that the patient either she presented to you have a hirsutism, or that she have a laboratory test say that the patient have high testosterone, androstenedione, or other investigation that done, which mean that the patient have hyperandrogenism. From this, we either will have phenotype A. Phenotype A include anovulation, the ultrasound picture, and hyperandrogenism. 60% of the patient presented to the outpatient clinic complaining from patient in the phenotype have the same complaint as the patient in phenotype A. Hyperandrogenism, either clinical or biochemical. Either the patient presented to you in the clinic complaining from hirsutism, acne, frontal baldness, or she has an investigation have high testosterone, for example. Chronic anovulation, such a patient have complaining from amenorrhea or oligomenorrhea, and by ultrasound she have a polycystic ovary. By ultrasound we will see it later on. For type P, we will see that type P is only that part of the cycle, only that part that include the anovulation and hyperandrogenism. No ultrasonic picture of polycystic ovary. Hyperandrogenism and chronic ovulation present 7% of the patients. C, 16% of the patients presented in C type. Chronic anovulation and polycystic ovary by ultrasound without hyperandrogenism. So the patient have no hirsutism, no acne, no frontal baldness, no any picture of hyperandrogenism, but she have irregular cycle, amenorrhea, oligomenorrhea, and the ultrasound show that the patient have a polycystic ovary. D. 16%. Hyperandrogenism and polycystic ovary on ultrasound. Hyperandrogenism and polycystic ovary on ultrasound, but with ovulatory cycle. That means that the patient presented to the outpatient clinic complaining from acne, hirsutism, frontal baldness, and there is a polycystic ovary by ultrasound, but she have a regular cycle. This is the types that may suggest that the patient have a polycystic ovary syndrome. And in order to distinguish this disease from other type which may present to us have the same picture and she have another diseases, we should exclude thyroids, for example, because thyroid hyperthyroidism may the patient presented with irregular cycle. She will have amenorrhea, oligomenorrhea. She may be complaining from hirsutism or extra, and the patient may we think that the patient have polycystic ovary syndrome, but she have thyroid disease. And other causes may be Cushing syndrome. The patient will complain from the same symptom. She will have also irregular cycle, and she have obesity, and she may have hirsutism or something. She may think that the patient have a polycystic ovary syndrome, and so you should exclude other causes and other diseases before we decide that the patient her professional diagnosis is polycystic ovary syndrome. The prevalence is 6 to 8% worldwide, and this is depending on the National Institute of the Health criteria, not Rotterdam criteria. This prevalence is very low in our society. In our society, we have a higher number than that. Pathophysiology. Neuroendocrine defect. This pathophysiology, in this explanation, they claim the hypothalamic pituitary ovarian excess as the cause of polycystic ovary syndrome. So the defect is initially from the brain itself as a cause of polycystic ovary syndrome in this patient from gonadotropin releasing hormone itself. Here in the patient with polycystic ovary syndrome, we know that there is hypothalamic pituitary ovarian excess which is should be intact in any patient have a regular cycle. The delicate balance of the hypothalamic pituitary ovarian axis in this patient is disrupted, resulting in abnormal follicle growth and maturation. And this will be subsequently will lead to oligo or anovulation. In women with polycystic ovary syndrome, this will display abnormal pattern of gonadotropin secretion. How we can know that the patient have abnormal gonadotropin secretion? Why we send the patient luteinizing hormone and follicle stimulation hormone. In this patient, we will see that luteinizing hormone has higher than follicle stimulation hormone. Luteinizing hormone with usually the ratio is equal to 1 or less. This is from LH-FSH ratio. But in this patient, we will see that LH have 4-fold increase over FSH hormone. That is because there is an increase LH pulse frequency and amplitude, while the FSH stay normal or low. The abnormal gonadotropin secretion, it is either due enhanced pituitary sensitivity to gonadotropin releasing hormone stimulation, or increased pulse frequency of gonadotropin releasing hormone secretion. Insensitivity of gonadotropin hormone releasing hormone pulse generator to the negative feedback effect of estrogen and progesterone. This is one of the explanation. The other explanation of impaired ovarian steroidogenesis. We should know that ovarian steroid is produced by the theca undergranulosa cell. This factory, which is theca undergranulosa cell, which is present inside the ovary, is the factory of ovarian steroid. How it is work? First, LH, which is secreted from the pituitary gland, will stimulate theca cell to produce androstenedione from cortisol. Cortisol is present there and in the theca cell, and the LH will stimulate the theca cell to convert this cortisol to androstenedione. Then it will be converted to estrogen in the granulosa cell. This is all work all together. The theca cell first initially will be stimulated from the LH to change cortisol to androstenedione. This androstenedione will be converted to estrogen in the granulosa cell by the action of FSH depending aromatase. So it is all work together. The LH first, LH stimulate theca cell, then FSH stimulate the granulosa cell. LH stimulate theca cell to convert cortisol to androstenedione. FSH will stimulate the granulosa cell to change the androstenedione to estrogen by aromatase activity. These two principal factors influence the total amount of androgen secreted by the ovary. The total number of the theca cell and their steroidogenic capacity. This both are disturbed in women will be in patients with polycystic ovary syndrome. The large quantity of androstenedione secreted by the theca cell are metabolized in the peripheral tissue because there is a large number of androstenedione. Not all will be converted into the granulosa cell. LH, we have a higher LH and in this patient, and will stimulate theca cell to convert cortisol on androstenedione, but the FSH stay normal and it is affect the granulosa cell only, and when it is stimulated the granulosa cell, it will convert the androstenedione into estrogen, but in a limited number, while the excess androstenedione will be secreted from the theca cell, will be metabolized in the peripheral tissue, such as in the adipose tissue, in the skin, and in the liver. This all tissues will converted into testosterone and estrogen. In fact, half of the circulating testosterone in the women derived from the peripheral metabolism of androstenedione. So, in such women, we will get an excess estrogen and excess testosterone, which is peripherally converted, not all inside the factory of the ovary. So, while you are in the outpatient clinic, what the polycystic ovary syndrome will bring the patient to you in this outpatient clinic? What is the presenting symptom? Either she will present with irregular or unproducible menstrual cycle, menstrual cycle. That the patient may have either oligomenorrhea or amenorrhea. The patient may have 3-month amenorrhea, 6-month amenorrhea, or the patient present with abnormal hair growth, and this is called hirsutism, acne, scalp hair loss, unexplained weight gain or overweight, infertility, and which is possibly associated with recurrent first trimester miscarriage. When she presented to you with these symptoms, we should examine this patient regarding this symptom. First of all, from the first look, you should also put in your mind the patient look, the body mass index, and general look. You should look to the patient generally. The patient have symptoms, signs that give a clue to you that she has a polycystic ovary syndrome, like her increased body weight, the patient have acne in her face, the hirsutism. How you will look for hirsutism? Hirsutism is defined as the presence of terminal hair in a male pattern, in a male-like pattern in a woman. The sides of the face and the chin area are frequently involved. Other areas include anterior chest, midline abdominal area, triangular male pattern pubic, and hair distribution in lower abdomen. So when you search for hirsutism, the patient will present to you complaining from abnormal hair growth. You should look where is that abnormal hair growth, and you have a map, a special map. We'll discuss it later. A special map. You will see the patient complain, and then you should look for that map of hair distribution to see the degree of hirsutism, if the patient have a serious hirsutism or not. Maybe the patient have a normal hair distribution and she complaining from hirsutism, and when you look to the patient, it is not a terminal hair. Terminal hair is the important picture. The terminal hair is the same that hair that is grow on the scalp of the hair, not that thin hair. So that the patient, in this patient, present like a male pattern of hair, not that thin hair present on the face that usually present in the female face. Acne, androgenic alopecia, which is frontal, obesity, you should look for obesity, and acanthosis nigricans. And acanthosis nigricans, which is mainly present in the patient with type 2 diabetes. Look at the darkness in the nape of the neck and on the axilla. This acanthosis nigricans is one of the signs of insulin resistance, which is usually occur in a patient with polycystic ovary syndrome, and we should look for it when the patient presented to you in the outpatient clinic. So collectively, when you look to the patient generally for her obesity, her body mass index, look for her hirsutism and over her the hair growth, acne, alopecia, acanthosis nigricans. This is a common sign for the general look. This a picture for that. Hirsutism, acne, frontal baldness. Method to determine the presence of hirsutism. We have a visual score that I explained to you. Well, this is called modified Fermat-Gallwey score. You can give a 0 score. This will represent absence of terminal hair. Terminal hair, you should look for terminal hair, the dark and the dark hair, which is thick hair, not that thin hair. And then we will score it. If the patient have a score of 4, represent an excellent terminal hair growth. Hirsutism is defined by a modified Gallwey-Fermat score of more than 6. If she have more than 6, that the patient have hirsutism. And some of the books said 8, give 8. So you should first score this patient according to the map. Biochemical feature of polycystic ovary syndrome. what we should look as a biochemical feature? We will have a hyperandrogenism in this patient. The measurement of testosterone or the free testosterone, free androgen index, are thought to be a sensitive method of assessment of hyperandrogenism. Testosterone is bound to sex hormone binding globulin and albumin, but mainly for sex hormone binding globulin, about 90%, 99%, while only 1% will bind for albumin. So when I want to look for hyperandrogenism in this patient, I should send the patient for free androgen index, free testosterone, sex hormone binding globulin, to see if the patient she have low sex hormone binding globulin. For that, the free androgen will stay free in the body and go for the target organ. Hyperinsulinemia, insulin resistance, is defined as reduced glucose response to given amount of insulin. So the patient have insulin, but the body is resistant insulin, and this may occur secondary to resistance at the insulin receptor. Hypothalamic pituitary ovarian axis, so that we should send the patient for serum LH and serum FSH to see if there is an elevation serum luteinizing hormone and there is normal or reduced follicle stimulation hormone. To look for ultrasonic feature of polycystic ovary syndrome, so we will send the patient for ultrasound. We will see that the patient have multiple follicles in the peripheral ovary. We can depend on only one ovary, not both of ovary have the same. Maybe it is enough to look for one ovary and she have that criteria. A presence of more than 12 of follicles. We see that we have about 12 when we calculated of which is peripherally distributed in the ovary. All these follicles are small, about 2 to 9 millimeter in diameter, small, and increase in the ovarian volume more than 10 milliliter. In at least one ovary, it will be diagnostic of polycystic ovary disease, but not polycystic ovary syndrome. We are not discussing the syndrome now. We're just discussing the ultrasonic feature. So that when we say there is polycystic ovary disease in that ovary, but it is not diagnostic for polycystic ovary disease, but because some of these criteria may be normal. So we should correlate it with the other picture of clinical picture of polycystic ovary syndrome. Now, we diagnose the patient from this criteria as she has a polycystic ovary syndrome. How? We diagnose it because she presented to us in the outpatient clinic complaining either from amenorrhea or oligomenorrhea, hirsutism either clinical or biochemical. We either clinically we see it and map it that she have a hirsutism or acne or frontal baldness, or the patient does a lab test, or the ultrasound give a picture. 2 out of these criteria would diagnose the patient of a polycystic ovary syndrome, and we now should treat it. How to treat? The first, we should explain to the patient that the disease is an endocrine disease, and this disease will stay with you your whole life, and this complication which is occurred now will be followed by long-term complication which is more important. We will discuss it later. So she should be aware from these whole complication. So for that, the patient first step to help herself, not we will help her, that she will need for lifestyle modification, and she should reduce her body weight, and she should control her diet, and she should do exercise in whole of her life, because when the patient is thin, that only reducing about 5 to 10% of her body weight will be enough to regulate her cycle and reduce the hormonal changes. Regarding if the patient, we will treat the patient accordingly, according to her complaint. If the patient have a normal cycle, you need to treat this patient. If the patient have her main complaint is about the hirsutism, you should treat hirsutism. If she only want to treat her infertility and she want a child, you should not treat hirsutism at this time, because that is another way of a treatment. You should treat infertility and the drugs which is regarding hirsutism and should be stopped. If the patient, her main complaint is hirsutism and acne, we need to treat. First of all, we do lifestyle modification, weight reduction and exercise. We can give the patient combined oral contraceptive like Diane. This Diane is anti-androgenic, have anti-androgenic effect and contraceptive at the same time, and also regulate the patient's cycle if she have a regular cycle. We can give her cyprostenone acetate by 50 milligram to 100 milligram in the first 15 days with oral contraceptive both. We can give spironolactone 100 to 200 milligram daily. Metformin, this metformin, it is not a treatment of hirsutism, but it is also a help in a treatment of patient who have insulin resistance, and we can give the patient together with treatment of anti-androgenic drugs. It can help you if you give it by 500 milligram 3 times daily. 500 milligram can help you, and this was the modality of the treatment with anti-androgenic drug. Dexamethasone, one of the theory that you give dexamethasone in 0.25 milligram, 0.5 milligram will treat hirsutism. And laparoscopic and ovarian wedge resection is some of the pics. Or researchers, they saw that after we do ovarian wedge resection, the patient have restore normal androgen action. How to manage infertility? If the patient have her main complaint presented to you as the patient is infertile, metformin may complement the effect of lifestyle modification. يعني when the patient presented to you with hyperinsulinemia and she have obesity and she have insulin type 2 insulin resistance or diabetes, you can give her metformin initially with lifestyle modification and exercise. This will give much improvement in her menstrual cycle and improve response to ovulatory agent. Then we stimulate the patient with the clomiphene citrate. It is to guard as the first line management, and all the new guidelines till now they give clomiphene as a first line method of ovulation induction in the patient with polycystic ovary syndrome. Started that from day 2 of the cycle till 5 days, starting by the lowest dose, and then increased this dose in the next cycle up to about 6 cycles. The second line of a treatment is gonadotropin if the patient have resistance to clomiphene, and if still the patient have a resistance, we can do laparoscopic ovarian diathermia. This for the patient with clomiphene resistance of a polycystic ovary syndrome. The complication, what is the complication of polycystic ovary syndrome? Either patient will present it with infertility, abnormal uterine bleeding or dysfunctional uterine bleeding, obesity, recurrent early pregnancy loss, clomiphene citrate more than 12 cycles will increase the risk of ovarian cancer, and ovarian hyperstimulation syndrome. This is the complication of the patient presented with polycystic ovary syndrome. The long-term health complication. Either patient have a metabolic syndrome, she will develop 2 to 3 times higher risk. Maybe have hyperlipidemia, diabetes mellitus, and type 2 diabetes will occur in 20 to 40%, will develop on impaired glucose tolerance and or diabetes mellitus from the 4th decade of life. Patient initially she only have an infertility, and in her later life she will develop diabetes or cardiovascular disease, because this will be higher prevalence of the major risk factor for this disorder. Hyperplasia and endometrial adenocarcinoma, because of continuously the uterus will be stimulated by estrogen, because the patient with PCOS have a higher estrogen that will continuously stimulate the endometrium, and this stimulation unopposed by progesterone will the patient will, the end result will make hyperplasia, and this hyperplasia in the endometrium will be developed into adenocarcinoma. If the patient gets pregnant, what is the risk in pregnancy? Spontaneous miscarriage in about 30 to 50%, impaired glucose tolerance, and gestational diabetes, may develop hypertension or small for gestational age. Thank you, and if you have any question, we can discuss it, and put your question, and if you have any query about this lecture, we can discuss it later on. And thank you for your listening, and goodbye, and keep safe and stay at home.